Greetings, everybody. Dr. Frank here with a training video regarding Sgarbossa criteria and identifying occlusive MI in left bundle branch block pattern and pace rhythms. As you all know, this is a new protocol for us, allowing us to activate STEMI alerts based on the presence of Sgarbossa criteria in left bundle branch or pace rhythms, and also in isolated posterior occlusive MI. And just as a reminder, we're still going to activate these as STEMI alerts, even though it's not a traditional STEMI pattern. It's just so the hospitals and the dispatchers and everybody sort of are speaking the same language. So it's not an OMI alert, which is technically more appropriate or accurate, but it's a STEMI alert. Okay, so if you identify Sgarbossa criteria, call a STEMI alert. To identify isolated posterior occlusive MI, call a STEMI alert. But there's been some confusion out there, and I know this is not an easy concept to grasp. So I just want to go over this again, and I'm going to go over it again in the future, the Sgarbossa criteria. So this is for left bundle branch block pattern or paced rhythm. And there's three criteria. You only have to meet one. And the three criteria are concordant ST elevation in any lead. Okay, so you can see any lead concordant ST elevation of 1 millimeter or more. And remember, concordant means that the ST elevation goes in the same direction as the QRS complex. So you can have concordant ST elevation or you can have concordant ST depression. But the first criteria is concordant ST elevation in any lead of 1 millimeter or more. Okay, so you can see the QRS complex goes up in this particular example, and the ST elevation goes up also. So that's concordant ST elevation, any single lead 1 millimeter or more. Second criteria, concordant, remember, so we're saying concordant again. So the QRS complex goes down, and this is concordant ST depression. This is in only leads V1, V2, or V3, okay, or V3. It doesn't have to be in all three leads, just one lead, greater than or equal to 1 millimeter of concordant ST depression in leads V1, V2, or V3. Okay, so remember, the QRS complex goes down, and you have concordant ST depression. Okay. And then the third criteria, which is the modified part, if you're familiar with the old criteria was greater than or equal to 5 millimeters. Don't worry about that. This new criteria is ST elevation to S ratio greater than 25%. So I always just think of it ST elevation over S greater than or equal to 25%. Okay. So what you do is you look at the ST elevation. So in this particular example, the ST elevation will count it out. Remember, each little box is 1 millimeter. Each big box is 5 millimeters. So this particular one is about 1, 2, 3, 4, 5, 6, just about 6 millimeters, maybe even a little more. Okay. And then the S wave here is 5, 10, 15, maybe like 16 millimeters. Okay. So 6 is the ST elevation over 16, which is the S. So ST elevation over S, 6 over 16 is 0.375 or 37.5%. That's obviously greater than 25%. So that would be a positive finding. Now, we had a case a couple of weeks ago of a positive Sgarbossa. It was the first criteria, which anecdotally, I don't know if there's any evidence to support this, is the most common criteria that's met, but and I'm going to go over that. But first, I want to go over what is a normal left bundle branch block pattern look like, and how do you define a normal left bundle branch? And it's defined as a QRS duration over 120 milliseconds, so a wide QRS. You have broad, right, wide, monomorphic, looks the same, R waves in the lateral leads. So in 1, AVL, 5, usually 5 and 6. So in this case, there's not a broad R wave in 5, but it doesn't have to be in every single one of these leads. And so remember, the first deflection down is Q, then up is R, and then down is S. So you don't have a Q wave here. You just have a broad monomorphic, meaning it looks the same, right? It's pretty symmetric. Broad R wave, broad R wave, broad R wave. Okay, and then you also have a dominant monomorphic S wave in V1 and V2. So this is just an S wave. So there's a very small R wave, usually very, very small or non-existent, and then you have a big S wave. Okay, so that's how you define left bundle branch block pattern. And when I look at left bundle branch, and if I'm looking for ischemia, which I do all the time, first you want to start is remember the three criteria. The first two criteria deal with concordance, right? So you want to have discordance. Discordance is good. Discordant means the ST elevation is going a different direction than the QRS complex. So what I do is I look for every lead to either be discordant or at least isoelectric, meaning it's the same on the same level, no elevation or depression. And if you find any concordance, then you stop and you say, okay, maybe we're having some problems here. But if you don't find any concordance, then you're good. So let's just go over this. So I just start and look at each lead. So this is discordant. This is isoelectric, right? So like the onset of the QRS. Maybe this is a little depressed, so it's still discordant. This is isoelectric, right? On the same line, basically. This is isoelectric. This is discordant, right? So the QRS goes up, the ST depression goes down, discordant, discordant. Obviously, this is discordant, V1, discordant, 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 and discordant. So you're done, okay, with those first two criteria. Then you look at the ST elevation and you say, is the elevation greater than a quarter of the S wave? So this is not greater than a quarter, even though we don't have little boxes that we can see. I think we can all look at these in our eyes, can tell that this ST elevation here is not greater than a quarter of this giant S wave. Okay, so there's no excessive ST elevation, there's no concordance. This is a normal left bundle branch block pattern. Okay, so let's go to our case, which was picked up by one of our excellent paramedics. This paramedic identified a left bundle branch block pattern. The paramedic identified that it met Sgarbossa criteria, activated the cath lab. The patient went to the cath lab, had a 100% left circumflex artery lesion, which was stented, and the patient did very well. This patient presents, this is the actual EKG. The patient presented with retrosternal chest pain for 10 minutes associated with diaphoresis and radiation to both arms. Remember, we don't like when the pain radiates. We don't want like when it's associated with vomiting. We don't like when there's associated with diaphoresis. Okay, so let's just identify that this is actually left bundle. Remember, it's greater than 120 milliseconds. Yes, you have these broad, monomorphic R waves in the lateral leads, right? So broad monomorphic R wave, broad monomorphic R wave, broad monomorphic R wave, broad monomorphic R wave. Okay, and then going back, you have dominant monomorphic S waves in V1 and V2. Okay, so maybe a teeny itty bitty R wave here and then a big S wave. Teeny itty bitty R wave and a big S wave. Okay, so this is left bundle. So now we're going to go through our Sgarbossa criteria. Remember how I do it is you look to see, is everything discordant? Okay, so if you find concordance, then you know there's some problem. So this is discordant, 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 discordant. This is isoelectric. This is either isoelectric or discordant. I would say that this is isoelectric, isoelectric. This is isoelectric. Now we're starting to have some problems here because it looks like there's some concordant ST elevation in the lateral lead here, V5. And then we go down to V6, and for sure, there's concordant ST elevation in lead V6. And remember, you only need one lead, and it has to be about 1 millimeter. And this is, if you see the onset of the QRS complex, this is 1 millimeter of concordant ST elevation in the lateral leads. So now you're done. You don't have to move on to excessive ST elevation. This is positive Sgarbossa criteria. This paramedic identified the Sgarbossa criteria being positive, activated a STEMI alert. The patient went to the cath lab and had 100% left circumflex artery lesion. And interestingly, if you're into following troponins, the initial high sensitivity troponin was non-detectable. And then he had another troponin in the cath lab drawn, and it was like really, really high. So this patient had an acute infarct, and went right to the cath lab and did very well. So just remember our protocol for STEMI or occlusive MI, but when we find these, we still call STEMI alert, just like we talked about. 1 millimeter of ST elevation, concordant, 1 millimeter of ST depression, and leads V1, V2, or V3 of ST depression, or excessive ST elevation greater than 25% of the ST elevation to S ratio. So hopefully that helps. This was a very, very good case, good example of a Sgarbossa criteria, and I thank you for your time.